Good morning, everyone, and welcome to our discussion on the brain and cranial nerves. I've split this lecture up into 3 separate videos. This first video, we're going to focus primarily on the protective layers of the brain, as well as how things like cerebrospinal fluid, which were mentioned a little bit last chapter, are going to be produced and then circulate around the brain. We're also doing a really big clinical in this particular video, so make sure you're taking notes on that part. In the second video, we're going to move up from the spinal cord, going through the brain stem and middle portions of the brain, as well as then moving into, in the last videos, our cerebellum and cerebrum. So let's get started. Okay, so we're not going to get into this in terrible detail, but if you recall from our discussion on development, we had our process of neurulation, which is where basically we form the neural tube and these neural crest cells in the 3rd week of development, sort of creating these pre-nervous system structures. Well, that neural tube, as we talked about in that chapter, part of it's going to become your spinal cord, and at the very, very anterior end, it's going to start to bubble out, and that bubbling is going to form what we call primary brain vesicles. They're like little bubbles of brain, and we refer to these as the forebrain, the midbrain, and the hindbrain. And these bubbles will then, as you go through fetal development, again, expand and differentiate. So for example, your forebrain will differentiate into what we call the telencephalon and diencephalon. So that's like step 2. These will then form these corresponding structures that we'll talk about as we progress through this chapter. So things like your cerebrum, which is the wrinkly part, the thinky part of your brain, your thalamus, and then various portions of the cerebrospinal fluid pathway. Your midbrain, this one's really nice and easy, is going to form the mesencephalon, which turns into the mesencephalon, so or midbrain. The midbrain we'll talk more about in our next video. It is the superiormost portion of your brainstem, and it is sometimes referred to as its name, the mesencephalon. Your hindbrain, this is going to form the metencephalon and myelencephalon, which is basically the remaining portions of your brainstem and your cerebellum, which are those 2 bulbous structures at the base of the brain. That is the level of detail that I care about with brain development. So we have 3 brain vesicles that turn into these structures, which then turn into the major structures. So primary vesicles, the secondary vesicles, and then the actual formed structures. That is the level that we care about. So moving on, the next thing I want to focus on are the major parts of the brain. So there are 4 major parts of the brain. We're going to go through all of these in this lecture. And starting at where the spinal cord enters the skull through the foramen magnum, we're going to start with our brain stem. Sometimes we call this our reptilian brain. This main set of structures, its job is to basically keep you alive. And we'll go into that in more detail later. Then we have our cerebellum right here, often referred to as the second brain because it looks like a little mini brain. We have our cerebrum, which is the big wrinkly part that when you think of brain, you're thinking of the cerebrum. And then here in the middle is our diencephalon. Now, in our last chapter, I did have a link to a video of a real unfixed spinal cord where you guys got to watch that kind of fresh out of a person. This is the same doctor, but with a fresh brain. And I highly encourage you guys to watch it simply so that you can see just how delicate and squishy your brain is. Because again, in anatomy, we typically look at things that are fixed, so they are more solid and not in their natural state. And this will kind of really help you with understanding why head injuries can be so devastating when you look at just how delicate the brain tissue is. So again, this link is in the PDF of the lecture. So, as mentioned, your brain is squishy. It's about the texture of Jell-O. And we want to make sure this is protected. And it's done through 3 ways. First, of course, you have your skull, which we have already gone into earlier in the semester. The second thing that we have that protects our brain are those layers of connective tissue wrappings called the meninges. And we talked about those in the last chapter. Your brain has the same sort of orientation of the meninges, but there's just a couple differences we'll talk about in a second. And then the third thing that's going to protect our brain is the fluid, the cerebrospinal fluid that is circulating both around and within it. So let's dive in first with our meninges. So here is a cross-section of the meninges. We actually have a model just like this in the anatomy lab. So you guys will get to see or have seen this in person. These are the hemispheres of your brain, and we can see this light pink layer is the pia. Then we have this filamentous space. Those are your the little projections off of the arachnoid matter into the subarachnoid space. And then we have this thick layer here of the dura. Now, first big difference between spinal and cranial meninges is that the dura matter has 2 layers. So if we look here, we have what's called the perosteal layer, which is the layer that's going to touch your skull. And then we have the meningeal layer, which is the deepest layer. So we have 2 layers of the dura, and these additional layers are actually going to come in, invaginate, and go between different portions of the brain. So we'll talk about this more, but this is your falx cerebri. It's going to go in between the cerebral hemispheres. You're going to have the tentorium cerebelli, which is going to go in between the cerebrum and the cerebellum. So they're just there again to support the brain. I like to think of these extensions of dura matter. If you've ever had a grapefruit, you know that the sort of outer skin around each segment is very thick. And then inside you have like the juicy grapefruit, but it's segmenting each one of those slices. That's what the dura here is doing. It's very tough, and it's separating different portions of the brain to help with support. The other difference is we have our pia matter, which is actually going to go around the blood vessels here. And the biggest difference, if you notice, here is my dura, and then immediately bone. There is no epidural space. In your spinal cord, remember, just outside of your dura, we had a cavity that was filled with fat. That was your epidural space. We do not have that here in the cranium because your brain needs to have as much room as possible to be as big as it can be. And if we have that layer of fat, it could potentially compress the brain, and it also limits the sizing of our brain in general. So we do not have an epidural space. Now, here's where our discussion on clinical connections is really going to come into play. What we're going to talk about right now is some head trauma. Now, people are going to have head trauma for a variety of different reasons. It's going to be presenting in a bunch of different ways. What I'm presenting to you is sort of a more typical presentation of what you would see in terms of someone that really hit their head very hard, and we're looking at these radiological images. Now, the 2 bleeds that I really want to talk about first are the epidural and subdural bleeds. So epidural, you just told me that there is no epidural space. That is correct. But you can bleed into the space between the bone and the dura. Now, this an epidural bleed is typically when a artery has ruptured, so it's going to come on, it's going to fill that space between the dura and the bone very quickly. So patients are going to have a much faster onset of symptoms, okay? When you look at this on the radiological imaging, you're going to see this lemon shape. Okay, so that is very characteristic of a patient that has an epidural bleed. Again, a lot of times you're going to have these major characteristics that you're looking for how a patient's presenting for a certain type of injury. But there's always those times when things don't go as you were expecting. But when you look under the imaging, you're going to see this sort of lemon-shaped cavity that's filled with blood. This is indicative of an epidural bleed. Now, the next one we have is a subdural bleed. So if we think about where we're at in our meninges, subdural, that's going to be the space between the dura and the arachnoid matter. Now again, these are typically coming on from trauma. Maybe you hit your head on the steering wheel, you got a baseball to the face, or you fell off your motorcycle, things like that. This is an example of a subdural bleed. Now this is going to happen when you rupture the veins in this area. Because you have ruptured veins, the leak is slower, and so you're not going to have as quick onset of symptoms, but you will still have symptoms later. So this is why, as first responders, we always want patients to get seen at the hospital, especially after car accidents, because sometimes you could have a bleed like this where you're like, I feel fine, I don't have a headache or anything, I'm totally okay. But because it's a venous bleed and it takes a lot longer for those symptoms to come on, you could go home, start to feel like maybe a little bit of a headache, and then 12 hours later, you could have this venous bleed and not know it and either die or be in very serious condition. So how do we see this on a CT scan? You're going to look for this sort of crescent shape, okay, or a banana. So one of the ways we like to differentiate is epidural is going to look like a lemon, and a subdural has a B, is going to look like a banana. Okay, now I have a third image over here. This is actually showing you a subarachnoid hemorrhage. This doesn't necessarily need to have trauma. This can come on spontaneously. This is usually where the patient presents with the worst headache of their life. Granted, that is also a symptom of lots of other things. But usually it's a rupture of one of the vessels in the circle of Willis. So it comes on really fast. It's very painful, sudden onset headache, neck pain. About 50% of the people here are going to lose consciousness. Okay. So these would all be considered head trauma, and those of you that are first responders do know that one of the things we do is we look for, are you alert, awake, and oriented, asking certain questions, having you track our finger when we are doing these assessments. We're going to actually talk about that eye movement, why we do that sort of finger tracking when we get into special senses and talk about the eye. Now, the next thing that I do want to talk about is something, and I would write this, but I don't have like actual tablet to write on right now, so it's better if I just say it. So one of the things that can happen with a brain bleed or trauma is, as you can see here on this particular CT scan, as that brain cavity fills with blood, it's going to compress the brain, and your skull as an adult is fused together. It does not expand. So as your brain either fills with fluid from something like hydrocephaly, which we'll talk about later, or in this case blood, it's going to increase the pressure in your brain. We call that ICP, or intracranial pressure, and this can cause lots of problems. So one of the things that we see in patients that have very severe head injuries, like really bad, is we can look for something called Cushing's triad. So Cushing's triad is something that occurs when your intracranial pressure increases. So the pressure on your brain is getting too high. What we typically see are an increase in your blood pressure and a decrease in your heart rate. So your blood pressure actually starts to do what we call widening. So the number, the top number, your systolic, and your bottom number, your diastolic, start to widen. So the gap between them starts getting bigger and bigger, and your heart rate is going down. I'm not going to get into this in too much detail right now. We could talk about it in lecture if you're curious, but the idea is this is a physiological mechanism. Your brain is trying to adjust the blood pressure to the brain, to decrease the intracranial pressure, but it also needs to get blood to the brain. So it's kind of this weird mechanism that happens. The other thing that we can see is as your brain is swelling or it has fluid on it and it is expanding, especially if it's swelling from things like either injury or infections like encephalitis, as that brain starts to swell, again, it has nowhere to go, but it does. At the base of your skull is how the spinal cord gets into the brain, that foramen magnum. That is an exit point. And in very severe cases, you can actually have herniation of your brainstem. And as we'll talk about later, one of the things that your brainstem does is it helps regulate your breathing. So what we can see sometimes with individuals is something called Cheyne-Stokes breathing. This is where patients are going to be breathing very erratically. They'll be breathing really quickly. We call that tachypnea. And then all of a sudden they go into apnea, which is where they stop breathing. So they're like, and then they keep doing that. That is a very severe sign. That means death could be around the corner. This is very different from agonal respirations, which you guys will learn about in your courses, either as a first responder or as a nurse. Agonal breathing is really wild. It's so unique. This is basically the last breaths. Your body is really trying to stay alive and it's not doing a very good job at it. And they're very, very unique in terms of those respirations. So this is one of the things that you'll see in Cushing's triad: the widening blood pressure, the heart rate change, the decrease in heart rate, and then you have your Cheyne-Stokes breathing. Again, all due to increased intracranial pressure because the brain is either swelling from injury or infection and it has nowhere to go. So there's your clinical connection. Now, let's talk about these meninges because they're supposed to help protect us, okay? We have, again, that dura mater that I talked about, the outer covering, very, very thick, again, like a grapefruit divider. These dura mater extensions, the meningeal layers, are going to divide into the brain, sort of how you see here, and we're going to look at one of these in lab. The one that goes in between your cerebral hemispheres is called your falx cerebri. We're going to have one that goes, you can kind of see it right here. It's again going to be vertical. This is going to go between your cerebellar hemispheres, and it's called the falx cerebelli. Again, just like a grapefruit section, just kind of separating these things out. And then we have the tentorium cerebelli, which is actually separating the cerebrum from the cerebellum. So these are what that second layer of the dura is doing, is helping create these little sections. Okay. Now, one thing that you'll probably get into either in physiology or in your other professional courses is something called meningitis. And meningitis is when these meningeal layers become inflamed, either due to bacteria, fungus, virus, and as you can imagine, it's going to lead to swelling, and that can lead to some severe complications. So the brain is protected by the skull, which we've covered. We just kind of talked about the differences between the spinal and brain meninges. The last thing we want to talk about is cerebrospinal fluid. And we touched on this in our last chapter, but I just kind of said, you have cerebrospinal fluid. We'll talk more about it. This is basically, it looks like water. It has the composition of plasma-ish. The ions might be a little bit different. But what this fluid does is it's going to circulate both within the brain and spinal cord and around the brain and spinal cord. And it's really, really important because it's a fluid, and fluid absorbs shock really, really well. So just everyday movements and even, more traumatic movements, this fluid can help take on some of that concussive force without relaying all of it to the delicate brain and spinal cord tissues. It's also there, it's circulated constantly. Basically, it's reabsorbed as fast as it's made, and what it does is it transports nutrients and wastes as well throughout the brain and spinal cord. Actually, while you're sleeping, this is another reason why sleep is so important. your cerebrospinal fluid is basically kind of cleaning itself out. So it's going to help not only with those metabolic wastes and metabolic needs, but it also ensures that all of the neurons that are in your brain and spinal cord have the right chemical environment. They have the right levels of ions, etc. So it's super, super important. Where does it come from? Well, I kind of gave you a hint already. I said its composition is very similar to plasma, and it's actually coming directly from your bloodstream. So if we recall, all the way back to Unit 1, we are looking at tissues here. And these are our ependymal cells, and they are stratified columnar. Okay, this is one of the, not stratified, sorry, ciliated simple columnar epithelium. And this is one of the places we can find it. So the function of simple columnar is secretion and absorption. In this case, we are absorbing unwanted wastes into the bloodstream, and we are secreting all those nutrients and good stuff into the cavities within the brain. So this bundle of capillaries that's surrounded by ependymal cells, which again are a neuroglial cell, this is called the choroid plexus, and we have them scattered around throughout the brain. So this is happening not just in a singular place. And this is how we get the formation of cerebrospinal fluid. The cilia here are there to help propel it. Now, not only do the combination of blood cell and epithelial cell provide the filtration means essentially to produce the cerebrospinal fluid, it also creates what's called the blood CSF barrier. So your brain, as we'll talk about in a minute, is very, very good at keeping stuff out. Sometimes it's too good. So we need to make sure essentially that we don't want unwanted items as we're making the cerebrospinal fluid, like viruses and things like that. We don't want that to get into the cerebrospinal fluid, because now it has free reign throughout the inside and outside of the brain. Now again, the body isn't perfect. Pathogens are very good at manipulating themselves to go across these barriers, but this is one way the brain is preventing just any old thing from getting into the brain itself. Okay? So these choroid plexuses are found in a lot of the ventricle walls in the brain. Now, when you think ventricle, don't think in the heart, just think like a cavity, like an open space. So we have 4 major ventricles. We have our 2 lateral ventricles that are inside the hemispheres of the brain. They connect at midline to our 3rd ventricle, which then drains down this really skinny, you can see right here, this really skinny ventricle called the cerebral aqueduct into our diamond-shaped 4th ventricle called the 4th ventricle that lives within like the brainstem and cerebellum. And within lab this week, I believe, you guys, I have a model that shows you what this looks like. So it's like a cast of what the hollow spaces of your brain look like. So you'll actually be able to practice this whole pathway that we're going to learn. So it's really great of really cementing these pathways down. Now, one thing again I want to preface before we get started here is we're going to talk about the cerebrospinal fluid kind of starting in one spot. But again, in reality, we have these choroid plexuses in a couple different places. So the fluid is continually being pushed into different areas. But again, as with anything when we teach, it's nice to have sort of a starting point. So if we start at the choroid plexus in the lateral ventricles, the fluid is going to go into the lateral ventricles and then exit through holes that we call interventricular foramina, okay, which are kind of these little holes in the ventricles that are going to allow it to escape and go down into your 3rd ventricle. The 3rd ventricle is going to flow into the cerebral aqueduct and go into that 4th ventricle right here. Now from here, we can move into different places. So we can use the median and lateral apertures. So the median in the middle and lateral on the outside. apertures like an opening. So we use these openings to go out of the brainstem and go into the subarachnoid space. And we're also going to continue straight down through the central canal, the spinal cord. So the fluid that goes down here just goes down into the spinal cord. And then the ones that are going around the subarachnoid space will go around the brain and spinal cord and eventually get reabsorbed back into circulation through these little projections here called arachnoid villi. These are projections, again, you're going to see this in lab. I have a whole model about this. These are projections that are going to stick right into that superior sagittal sinus. So we start with capillaries filtering out the blood, producing cerebrospinal fluid, flowing through these different openings and cavities within the brain, around the brain, and then we get back into that circulatory system through the arachnoid villus into the superior sagittal sinus. Now again, one thing that can go wrong here is sometimes this pathway can get blocked, and this is something that's a little bit more common in infants than in adults. But what you see here is a child that has what's called hydrocephaly or hydrocephalus. And for one reason or another, the pathway is blocked. And so what that means is your body is still making that cerebrospinal fluid, but it can't get out. And so what happens is an ultrasound. You can see here's our fourth ventricle, our third ventricle, and our lateral ventricles. Just completely, this is also part of your lateral ventricle. These are completely engorged and stretched with fluid because it can't exit the fourth ventricle for some reason. Now, the reason this infant has such a dramatically large head is that if you recall from our discussion on the skeletal system, babies have fontanelles, these little soft spots to help with birthing and that rapid expansion of the brain as they're going through development. So their brains are not sort of fused into a singular finite space. It has room to expand. So that's what you see with hydrocephaly, these sort of enlarged, sort of bigger than normal heads. Oftentimes we, are going to catch this early during your well baby visits. But basically what they do is they'll have to have surgery and they'll put a shunt in, which is just a little tube that will open up the clog essentially, and that will drain usually into their abdomen, and it will help relieve the pressure, drain the excess fluid, and their heads will go back to normal. And most children that have hydrocephaly go on to live completely normal lives. So this is a video about an instance of that where the baby was acting a little bit weird, wasn't feeding right, and they noticed their head was a little bit bigger, and it turns out they had hydrocephaly. So it kind of goes through the process of getting the diagnosis, the treatment, and then how the child is doing after. All right, let's chat about our last slide for the day, talking about the blood-brain barrier. So we talked about the blood CSF barrier, which again is those ependymal cells and capillaries in the choroid plexus. Those are preventing things from getting out of those areas of the bloodstream and into the brain. This is the formation of a separate barrier for the blood vessels that are feeding the brain itself. So what we see here are the capillary walls. So this is the simple squamous epithelium with tight junctions because we don't really want too much leakage here. We have our basement membrane, and then these are the projections of astrocytes. So we talked about our astrocytes in our discussion on like the intro to the nervous system. These are cells that do a lot in the brain, and one of them is to form the blood-brain barrier. So what happens is these tight junctions, these extra layers around the capillaries are really going to prevent things from coming out. So as you can imagine, large things shouldn't be able to get through, and so this usually prevents things like pathogens from infecting your brain, but it also prevents a lot of medications to get into the brain. This is why it's often hard to treat different illnesses in the brain or mental disorders because we may not have the right drug that can get through into the system. So the reason I like to talk about this is twofold. One, if you're heading into pharmaceuticals, this is something that you have to think about when you're developing a new drug for something like Parkinson's, or for antibiotics to treat encephalitis. You have to make sure it can get through this blood-brain barrier. The other thing, and you guys will learn about this more in microbiology, is there are pathogens that can manipulate this blood-brain barrier. So for example, group B strep, as well as Toxoplasma gondii, which is a parasite essentially, can cross the blood-brain barrier. So group B strep and Toxoplasma are two diseases that are very much of a concern if you're pregnant. You get a group B strep swab when you are getting ready to deliver, because it typically lives in your gut and can travel fecal oral. And Toxoplasma gondii is the reason they often tell pregnant women that have cats, don't clean your cat box, especially if you have an inside-outside cat, because they can have this parasite that basically can affect a lot of the fetus in terms of brain development. Most women are totally fine. I clean my cat's cat box. My son's all good. So, but I like to talk about that because the inflammation from those particular infections, as well as others, can cause these capillaries to get leaky, which means those tight junctions open up, and now they're able to exit and get into the brain and wreak havoc. So that is that for part 1. In our next video, you guys, we're going to start talking about the brain stem. So I'll see you then. Bye.